Hello and welcome to The Good GP, the education podcast for busy GPs. Today, we're presenting a short, special episode to give our audience an update about measles. I'm delighted to be joined by Dr Ramya Raman, RACGP Vice President, to talk about diagnosing measles. Ramya, welcome to the podcast.
Thanks, Tim. Thanks for having me on.
Right, let's dive straight into it, Ramya. Most of us would never have seen a case of measles before in our careers. It can be a real challenge to diagnose.
Yes, Tim, and thanks for asking about it. Measles has been really uncommon in general practice for decades now, and the reason for that has been because of a highly effective immunisation program, which ultimately means we're achieving great herd immunity. So, having said that, though, we're in a changing environment at the moment, and we may be seeing more outbreaks of measles going forward due to the declining vaccination rates, both locally, globally, and internationally as well. So, probably the most worrying change that we're seeing recently is we've seen quite a few outbreaks in Europe as well as in the US. And there have been some instances of mortality arising from measles in places, especially like the United States of America.
Yeah, really troubling times. So, okay, perhaps we can just give our GPs a quick refresher of who's at risk of measles and how it spreads.
Really good question, Tim. So, measles, as we all know, is incredibly contagious. So, with an R number of 12 to 18, which is much higher than many other infections. So, people who may be at risk for this are those who are unvaccinated or partially vaccinated, travelers to and returning from regions of outbreaks, individuals with a weakened immune system, or potentially vitamin A deficiencies.
You mentioned partial vaccination there, Ramya. What does partial vaccination mean?
So, partial vaccinations is primarily when it's usually two vaccines that are received for measles, which is given in combination as an MMR. And if only one has been received, then that becomes trickier. So, measles vaccine began in the early 1970s. And then up until about 1989, most people only received one dose of the vaccine. But then studies have later showed that a single dose doesn't provide sufficient immunity to everyone. That's exactly why that second dose was introduced as part of the routine schedule starting in 1989. So people vaccinated before that time may have lower levels of immunity.
Right. Okay, Ramya. I mean, this is the question most GPs would be asking. What or how does measles present? What should we be looking for?
Sure. So if we think about a really typical textbook presentation, measles cases will usually begin with what we call prodrome phase. So this phase can be around about 2 to 4 days, and it's usually marked by a fever, typically 38 degrees and above, which can also be accompanied by corizal symptoms. So we're talking about running nose, cough, potentially conjunctivitis. So the three C's. So to recap on that, cough, coryza, and conjunctivitis. During this time, patients, they generally look quite unwell. And there's also something we may all remember from medical school known as Koplik spots. These are tiny bluish white spots on a red background inside of the cheeks. And they're quite mnemonic for measles, but they can be subtle and very easy to miss as well. So potentially, as the illness progresses, the rash phase then begins, and that usually is around about 3 to 5 days after the prodrome starts. The rash is usually red, maculopapular, meaning that it can be both flat and raised spots. It starts on the face around the hairline and spreads downwards towards the neck, trunk, then the arms, legs, and then the feet. So initially, it's quite spotty. So the rash then may merge altogether over the body and makes it into more blotchy sort of patches. On the darker skin tones, it may appear a little bit more purplish or darker than the surrounding skin, which sometimes makes it a little bit harder to actually identify it. So the prodrome symptoms are quite important. And finally, it's really important to consider the general appearance of the patient. And we're all GPs. We all know that we have to look at the whole patient. Looking at the patient holistically is really important. They often look really unwell. So watching for signs of generally feeling lethargic or lethargy, dehydration, when the eyes tend to glaze over a little bit, and a really flat appearance of the patient.
Great tips, Ramya. I mean, rashes can be quite tricky. I mean, especially over winter, we'll often see kids with viral illnesses and rashes. What should we do if we're not sure about it potentially being measles?
Absolutely, Tim. And rashes sometimes can be so tricky, as you said. So, a really high degree of suspicion is the key. So, especially if the patient has travelled recently or is unvaccinated. So, I guess we also have to then think about perhaps testing as well, if we're considering that it could be measles. So, arranging for a PCR test using a throat swab or a first catch urine sample for viral RNA detection. But the other option could be serology, which can be used to detect the IgM antibodies. However, if IgM testing is negative within about 3 days of the rash onset, repeat testing 4 to 14 days later may be needed.
Yeah. So, any tips, Rami, if we do see someone who might have measles, about sort of containing it, and tips for the practice in general?
Yes, absolutely, Tim. So minimize exposure. That's number one. So isolate the patient upon arrival or assess them at home if that's an option. Some may be assessing patients who are unwell in the car park as well. So that could be another option. If so, using airborne precautions like the N95 mask and ensuring there's proper ventilation at the practice is also really important, and notifying the public health authorities. They're really essential in helping to manage such outbreaks. And remember, measles is a notifiable disease. So you'll need to notify your local public health unit immediately for guidance on testing and also containment measures.
Rania, thanks so much. It's really timely to get this update. I really appreciate you coming on the podcast.
And thank you so much for having me on the Good GP podcast, Tim. And it's been a great opportunity to also just update for myself as well as the other GPs so that we can look after our communities.